Okay, so this is the TOG article summarized, which is the stroke in pregnancy one. Quite a useful article for the MRCOG exams. I hope you'll find this video useful, and if you do, then please do give this video a thumbs up and subscribe to my channel if you haven't already. So, stroke is acute focal injury of the central nervous system. It's by a vascular cause, including cerebral infarction, cerebral venous thrombosis, intracranial hemorrhage, and subarachnoid hemorrhage. It's a second leading cause of death. It's a third leading cause of adult disability. 1 in 6 people at risk of experiencing stroke in their lifetime. It leads to some sort of neurological deficit. Most strokes, 90%, occur peripartum or 6 weeks following delivery. Fatality in hemorrhagic stroke is about 13.9% compared to 3.4% in ischemic stroke in pregnancy. Residual disability is higher in hemorrhagic stroke, 50% compared with ischemic stroke, which is 33%. Intracranial hemorrhage being the single greatest cause of maternal death from stroke. Most strokes in the general population are ischemic, 80 to 85%. But in pregnancy, ischemia, hemorrhage, and venous thrombosis have similar contribution to the etiology. So differences are because of in your obstetric population, you have a younger age profile. There's greater incidence of central venous thrombosis and intracranial hemorrhage, and hence why there's relatively fewer ischemic strokes in that particular population. Things like vascular dissections, aneurysms, arteriovenous malformations, and congenital cardiac conditions are all common etiologies in the younger population. Risk of central venous thrombosis is increased by physiological upregulation of clotting factors in the pregnancy, increase the hypercoagulability of the blood, also include things like ovarian hyperstimulation syndrome, hyperemesis gravidarum, and preeclampsia, all making the blood more likely to clot and hence form a thrombus, and therefore causing the risk of central venous thrombosis is even higher. So prothrombotic things like antiphospholipid syndrome, sickle cell disease, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, mechanical heart valves, and cardiomyopathies all increase the risk of ischemic stroke. Hypertensive disorders of pregnancy, including preeclampsia and eclampsia, increase risk of hemorrhage or ischemic stroke and can be associated with posterior reversible encephalopathy syndrome and reversible cerebral vasoconstriction syndrome. Amniotic fluid embolism is rare, pregnancy-specific condition that has been associated with stroke. So clinical presentation, symptoms and signs: rapidly developing symptoms, signs of focal cerebral loss of function and no cause other than that of a vascular origin. It's sudden, it's focal symptoms and clinical deficits confirming to a vascular territory. Symptoms like unilateral numbness or weakness of face, arm or leg, dysphagia, hymanopia, and cerebellar features such as dysarthria and ataxia. Non-focal symptoms like generalized weakness and or sensory disturbances, lightheadedness, brief loss of consciousness, urinary or fecal incontinence, confusion, and tinnitus are less likely to be caused by a stroke. CVT accounts for only 40% of typical stroke symptoms and signs. So hypertension and bradycardia together should raise the suspicion of intracranial bleed. It's clinically difficult to distinguish between intracranial hemorrhage and from ischemic stroke, but headache, nausea, vomiting, and a depressed level of consciousness are more common in a hemorrhagic stroke. Blood pressure tends to be higher in intracranial hemorrhage than in acute ischemic stroke. A relative bradycardia may be seen in severe intracranial hemorrhage with associated raised intracranial pressure. Seizures occur following a stroke. In pregnancy, any new onset seizure after 20 weeks and up to 2 weeks postnatally um, should be investigated and thought as to the underlying cause being eclampsia unless proven otherwise. So investigations and management of stroke, suspected stroke, you should do a non-contrast CT, will provide the necessary information to make decision about acute management, such as intravenous thrombolysis. Intracranial hemorrhage is a contraindication to thrombolysis, with management directed towards hemostasis and correction of coagulopathy with surgical intervention if appropriate. If there is thrombosis, then it's treated with full anticoagulation with heparin. Thrombectomy and local intravenous thrombolysis may be required. So CT angiogram is to look at large vessel disease and to check for any occlusions. A most accurate assessment of site of occlusion, the infarct core, the salvageable brain tissue and collateral circulation can be done by doing a CT perfusion and CT angiogram. CT angiogram has a high diagnostic value in detecting high degrees of cerebral arterial stenosis, whereas CT perfusion provides high specificity in detecting infarction and ischemia of the brain tissue. MRI further distinguishes between stroke subtypes and vascular imaging, either with carotid Doppler or magnetic resonance angiogram. Magnetic resonance angiogram of extracranial and intracranial vessels may be helpful for further evaluating posterior circulation strokes if CT angiography is unavailable. In eclampsia, PRESS, which is posterior reversible encephalopathy syndrome, is demonstrable on CT. Presentation of PRESS is similar to stroke. Signs and symptoms of neurological deficit may not be unilateral. Commonest areas are parieto-occipital, followed by frontal, temporal, and more rarely cerebellar regions, basal ganglia, thalamus, and the brainstem. So prompt imaging is important, and early treatment and is important to optimize outcomes. MRI is the first line imaging modality in pregnancy. There's potential hazards include theoretical biological damage related to cell migration, proliferation and differentiation, tissue heating, and potential damage to the fetal ear caused by the high acoustic noise level. No harmful short or long-term effects have been shown following MRI in pregnancy on the fetus. The fetal radiation dose in a non-contrast CT of the brain is approximately 5% of the naturally occurring background radiation dose. CT angiogram safety in pregnancy. It's safe. It causes less radiation exposure than CT perfusion. There's theoretical risk of fetal thyroid suppression. So neonatal thyroid function tests should be monitored in the initial 2 weeks of life. Gadolinium chelate to enhance MRI. So this passes into the placenta and may accumulate into the amniotic cavity with contrast medium cycling through the fetal gastrointestinal and genitourinary tracts. Studies have shown that only 0.01% of the gadolinium dose remains present in the fetus after 4 hours, and only traces remain after 24 hours. So the American College of Radiology states that gadolinium-based agents should be used with extreme caution and following well-documented informed consent. So investigations for underlying causes of stroke, so you do things like 12 lead ECG, transthoracic echo, transesophageal echo can be performed if transthoracic echo gives equivocal results. Internal carotid and vertebral arterial dissections are rare, but Doppler imaging can be done. If a preeclampsia suspected, FBC using these LFTs and uric acid can be done to look out for HELLP syndrome. Hypoglycemia and hyperglycemia can also mimic focal neurological symptoms, so they should be checked and corrected. Blood test for a full blood count, coagulation using these LFTs, lipid testing, factor V Leiden, um, or should be done, as some of the clotting problems can increase risk of um, hypercoagulable state. But some of these can be abnormal in the pregnancy, so they are usually left to be done postpartum. So complete thrombophilia screen repeated at least 6 weeks postnatally. So management of stroke, intravenous thrombolysis, irrespective of age or stroke severity, and despite risk of hemorrhagic transformation of 2 to 6% in the first few days after treatment, recombinant tissue plasminogen activator, RTPA, significantly improves the overall odds of good stroke outcome when administered within 4.5 hours of stroke onset. Benefit of therapy is time dependent and treatment should be initiated as soon as possible. The American Heart Association, American Stroke Association guidelines recommend IV tissue plasminogen activator. Treating moderate or severe stroke outweighs the increased risk of uterine bleeding. It does not cross the placenta, the theoretical risk of placental bleeding in IUFD. Antenatal patients should be observed for vaginal bleeding, intra-abdominal bleeding, pain, and further neurological signs. Ultrasounds can be done to observe for retroplacental hematomas and to assess fetal well-being. So mechanical thrombectomy with stent retriever devices are superior to the intravenous RTPA alone in acute anterior circulation ischemic stroke. Thrombectomy patients should be monitored in ICU until stable, with fetal well-being assessed with ultrasound before and after procedure. Thrombectomy can only be performed in specialized centers and only appropriate in 10% of cases of strokes, acute ischemic strokes. So management of intracranial hemorrhage, as we said, should be the correction of the coagulation profile that's making them bleed. Surgical intervention may be required, such as surgical decompression. Management of central venous thrombosis, we said, requires full anticoagulation with probably low molecular weight heparin or unfractionated heparin. Press in the pregnancy associated with preeclampsia or an eclampsia. So other conditions associated with PrES include hypertension, infection, sepsis, shock, autoimmune diseases, drugs, chemotherapy, and massive transfusion. Treatment of PrES is directed towards optimizing blood pressure control, removal of or treatment of suspected causative factors, and in the case of preeclampsia and eclampsia, delivery of the fetus. PrES resolves spontaneously with recovery within days to weeks. The patient should be looked after in a stroke unit. A multidisciplinary approach should be used to manage the patients with expert nursing care, specialist medical treatment, optimizing treatment protocols, coordination of rehab services, and patient education. Admission to a stroke unit does mean that the mother and baby need to be separated, which can affect bonding and feeding and so forth. Secondary prevention strategies should be deployed. Recurrent strokes happen in 25 to 30% of all strokes. So administration of aspirin is recommended in acute ischemic strokes within 24 to 48 hours of onset. For patients receiving thrombolysis, aspirin is delayed until 24 hours later. When ischemic hemorrhage stroke has been excluded, in patients presenting with a minor stroke or transient ischemic attack, treatment with dual antiplatelet therapy, that's aspirin and clopidogrel, should begin within 24 hours and continued for 21 days. and can be beneficial for early secondary stroke prevention. Aspirin use in pregnancy is well documented. It's recommended that treatment with clopidogrel should not be withheld because of pregnancy if deemed necessary. Clopidogrel should be stopped 7 to 10 days before a scheduled delivery if spontaneous labor occurs or delivery is expedited. While on a clopidogrel, neuraxial anesthesia is not recommended because of the potential increased risk of spinal or epidural hematomas. In acute ischemic strokes, in setting of atrial fibrillation, oral anticoagulation within 4 to 14 days of onset of neurological symptoms. Warfarin is a vitamin K antagonist across the placenta. Exposure in the first trimester is associated with warfarin embryopathy, and second and third trimester exposure associated with possible neurological sequelae, including seizures, developmental delay, hypotonia, and intracranial um, problems. Anticoagulation of choice in pregnancy is low molecular weight heparin or unfractionated heparin. Low molecular weight heparin does not cross the placenta and is not teratogenic. Antenatal central venous thrombosis is treated with low molecular weight heparin. High intensity statins is first line therapy who have clinical atherosclerotic cardiovascular disease unless contraindicated. When there's pre-existing diabetes and other potential co-founders, the apparent risk of congenital malformation of statins was no longer present. So timing of starting and restarting statin therapy postnatally should be based on an individual care plan. Smoking cessation should be advised for secondary prevention of stroke. So mode of delivery, no studies have said cesarean is safer than vaginal delivery following stroke. Decision on mode of delivery requires MDT input, early epidural to reduce fluctuation in maternal blood pressure, shortened second stage with elective operative vaginal delivery to prevent prolonged Valsalva and increased intracranial pressure. So postpartum management, it's a high risk period for venous thromboembolism and stroke. Anticoagulation continue for at least 6 weeks postpartum, depending on the timing and etiology of stroke. MDT input is required postnatally. Secondary prevention strategies should be deployed, and rehab and further investigations should be carried out. Although the role of routine post-stroke thrombophilia screening in the general population is unclear, factor V Leiden, heterozygosity, and persistent lupus anticoagulant is associated with increased risk of transient ischemic attacks, emeresis, fugus, and ischemic stroke. The presence of thrombophilia also has significant implications for future pregnancies. A complete thrombophilia screen should be therefore checked. Warfarin, low molecular weight heparin, and aspirin are safe to be taken while breastfeeding. Clopidogrel is classified as category B based on limited data, and therefore breastfeeding should be encouraged. Advice on postpartum and long-term contraception must be considered carefully. Combined hormonal contraception is contraindicated, and non-hormonal forms of contraception are recommended. For women taking progesterone-only contraception, the risk of recurrent VTE has been a subject of a debate. Evidence is limited, and this contraception can therefore be considered. Um, there is no increased risk in stroke in women taking progesterone-only contraception. However, the duration of use in relation to the onset of stroke should be carefully considered when deciding whether continuation of the method is appropriate. Preconception care, so counseling with previous history of stroke should be individualized depending on the etiology of stroke. Statins, clopidogrel, vitamin K antagonists are usually discontinued. Blood pressure control is optimized. Using pregnancy-safe medications and preconceptually, aspirin is safe and has been shown to prevent delay preeclampsia and growth restriction in high-risk women. So it can be continued in future pregnancies. High thrombotic risk is if it's present, the low molecular weight heparin should be commenced. Pregnancy complications high in women with prior stroke, probably secondary to underlying cardiovascular pathophysiology. The overall risk of stroke recurrence is reported to be 0 to 1.8% in subsequent pregnancy and 0.5% outside pregnancy. In women with concurrent thrombophilia, the risk has been quoted to be 20%. Future pregnancies should be closely monitored for complications. The pregnancy care plan for women with prior stroke should be individualized on the etiology of stroke and individualized risk of each woman. So MDT should involve obstetrics, neurology, radiology, neurosurgery, cardiology, and aesthetics. In acute ischemic stroke, the choice of therapeutic intervention depends on severity, pregnancy status, and anticipated risk of bleeding. Identifying the underlying cause and secondary prevention strategies need careful evaluation. Um, Information, advice, and opportunity to talk about impact of illness should be offered to all patients. This is the modified Rankin scale. So it's a score where you have 0 to 6. 0 is no symptoms at all. 1 is no significant disability despite symptoms, able to perform all usual duties and activities. 2 is a slight disability, unable to perform all previous activities, but able to look after own affairs without assistance. 3 is moderate disability, requiring some help, but able to walk without assistance. 4 is moderately severe disability, unable to walk without assistance and unable to attend to own body needs without assistance. 5 is severe disability, bedridden, incontinent, and requiring constant nursing care and attention. 6 is dead. So investigations for underlying causes of stroke in a young women, we said 12-lead ECG, 24-hour cardiac monitor, prolonged cardiac monitoring, transesophageal echo, transthoracic echo with the bubble test, full blood count, user-knees, LFTs, coagulation and uric acid, lipid profile, thermophilic screening, carotid and lower limb Dopplers. Post-stroke thrombolysis care, so 24 hours of bed rest, maintain oxygen stats above 95%, maintain normal temperature, use paracetamol if temperature is above 37.5, maintain blood glucose less than 10, deep vein thrombosis prophylaxis with intermittent pneumatic compression devices, no arterial lines, nasogastric tubes or central lines for 24 hours, no urinary catheter until at least 1 hour after infusion ends. Avoid suction and careful mouth care. No aspirin, clopidogrel, dipridamole, or anticoagulants for 24 hours. Repeat CT in 24 to 36 hours. Hydrate and nutrition, full risk assessment, prevention, stop RTPA if neurological deterioration of 2 points on Glasgow Eye or Motor Scale, observe for signs of systemic bleeding, stop RTPA, blood pressure, stop RTPA if systolic blood pressure is less than 100 or greater than 180 and diastolic is above 105. If sustained for more than 5 minutes, observe for signs of anaphylaxis, stop RTPA. RTPA meaning it's recombinant tissue plasminogen activator. So contraindications to thrombolysis is absolute and relative. I think what's most important is pregnancy is actually a relative contraindication to thrombolysis. That's it. That's a summary of the stroke and pregnancy article. I hope you find this video useful, and if you do, then please give this video a thumbs up and subscribe to my channel if you haven't already, and leave any comment if there's any useful content that you'd like to watch, and that'll help you with your revision. Good luck revising.